Hello, everyone, and welcome to our second of three measurement-based care educational panels in partnership with Greenspace Health and the Yale Measurement-Based Care Collaborative. My name is Jesse Hayman. I'm the Chief Growth Officer of Greenspace Health, and I have the pleasure of being your host for the panel today. Before we kick off, I wanted to start with a bit of a refresher around who the Yale Measurement-Based Care Collaborative is and who Greenspace Health is. Mostly because a lot of you were not on the first session, so just get to know us a little bit. The Yale Measurement-Based Care Collaborative is a group of 4 psychologists, the 4 wonderful people sharing the screen with me, that are focused on advancing research around measurement-based care, as well as industry education around the impact the measurement-based care can have, and implementation strategies dependent on different types of care settings. Greenspace Health is a leading measurement-based care technology organization. We work with hundreds of organizations across the US and Canada to help them implement measurement-based care, whether it's a small clinic, large clinic, hospital, health system, and help them inform their programs from client level to high-level data around the impact that their services are making and how to change them to improve quality of care services overall. With that said, I want to speak a little bit to the momentum we're feeling around measurement-based care. I think all the people on the call with me can speak to this, as well as myself, of that momentum for measurement-based care continues to grow. And on the Greenspace side, we can see that through the increasing velocity of organizations reaching out to learn about measurement-based care and for help with implementation of measurement-based care in their clinic. But we can also feel it through or indicated by the interest in this panel. Our first panel, we were hoping to have about 100 people register. We had over 400 people register. And same for this panel, we had about just over 400 people register. And I think it's a good indication around that increasing momentum, which is amazing news for the industry overall. We know the impact that measurement-based care can have, that engaging clients in a more collaborative way can have on their experience in care, but also their outcomes in care. And the effect that it can have on a clinical level for an individual clinician, but a clinic across the board, as well as our entire industry, and just upping the level of services that we provide. With all that said, when there's significant change, there's a need for education. And that is where this partnership between Greenspace Health and the Yale Measurement-Based Care Collaborative came from. We are on the second of 3 panels. The first was really about high-level definition and understanding of the impact that measurement-based care can have. And this one is much more about how to effectively use measurement-based care when working with an individual client and how to interpret and look at data to inform care overall. So really excited to get into that with all of you, but really wanted to take a second to just say thank you for being here. We hear all the time, especially during the pandemic and now how busy and overwhelmed a lot of clinicians and clinical leaders are. So very appreciative of you all taking your time to be here to learn about measurement-based care and to hear from these 4 amazing panelists. So thank you. At the end of last session, we put up a survey on screen and about 100 people filled it out. And the biggest piece of feedback that came from it is that people wanted to hear in the next session practical examples of how to apply measurement-based care in action, how to look at data and actually use that in practice. And that is, you're going to see, is a big part of our session today, is going through a couple examples together in an activity that the Yale team calls the PHQ-9 in 3 ways. So we will hop into that. But when we do, really encourage participation. Throw your thoughts and your insights into the chat. It is really a group exercise. The other couple things I just wanted to mention is there is a Q&A area at the bottom of your screen. If you have any questions throughout, please throw them in there. Dr. Elizabeth Connors is going to be answering through the chat throughout, but we'll also make sure to get to as many as we can at the end. And lastly, there will be a survey that pops up near the end or at the end when you try to log off. We will use that survey and your responses to make sure that the next session is as valuable to you as possible. So any insight or thoughts you can think of that would help us form that session would be remarkably appreciated. With all that said, I have the immense privilege to introduce my friends and colleagues from the Yale Measurement-Based Care Collaborative, and I'll pass it over to them to introduce themselves. We have Dr. Sandy Resnick, Dr. Elizabeth Connors, Dr. Jessica Barber, and Dr. Amber Childs. Why don't we start with Amber and we'll go from there.
Hi, everyone. Good afternoon. It's our pleasure to be here. I'm Dr. Amber Childs. I am an assistant professor of psychiatry at Yale School of Medicine. I am also a clinical psychologist by training, and I primarily specialize in working with children and adolescents. And my work in measurement-based care has really been around system-based implementation, particularly in a hospital-based system, and really thinking about specialty applications of MBC, if you will. So thinking about group-based applications or youth serving settings that are doing measurement-based care. So excited to be here and to talk with you all about MBC today.
Just to help, why don't we throw it to Jessica next?
Thank you. Hi, everyone. My name is Jessica Barber, and I'm also a clinical psychologist. My specialty is clinical health psychology, and I'm an assistant clinical professor at Yale School of Medicine, Department of Psychiatry. I am a practicing clinician, and I use measurement-based care, and I also work in implementing measurement-based care across a large medical system. I'm really excited to be here.
Awesome. Thank you, Jessica. And I'll throw it to Sandy.
Hi, good afternoon, good morning, wherever you are. I'm Dr. Sandy Resnick. I am a professor of psychiatry in the Yale School of Medicine, and I am a clinical psychologist with a background in psychiatric rehabilitation, which is helping people with the most severe psychiatric disabilities live meaningful lives in the community. And I've been in mental health for over 30 years. And for a good chunk of that time have been working on implementing evidence-based practices across large systems, and have recently, although trained in measurement-based care as a graduate school, and have always been a measurement-based care clinician, has more recently fallen in love with measurement-based care. And I'm so excited to share our passion for that with all of you today.
And last but never least, Elizabeth.
Thank you so much. My name is Elizabeth Connors. I'm a child clinical community psychologist and an assistant professor of psychiatry at the Yale School of Medicine. I primarily do work in implementation of evidence-based practices, including measurement-based care in child and adolescent settings. I'm really interested in community-based mental health, with a specialty also in school-based mental health settings, and just getting really curious about what implementation supports we can put in place to help clinicians, use more measurement-based care in their everyday practice in publicly funded settings.
Awesome. Thank you all. So I'm going to start by talking a little bit about our usual, traditional process of measurement and the difference, I think, to measurement-based care and in some of the pieces that are needed. And I think will inform the share side of our conversation that we want to have. I think when you think about our usual or traditional measurement, it's often not very frequent. So we're not consistently asking clients for feedback on how they're doing in care, their experience in care. And because of that, the results that we end up sitting with are not that useful in the clinical setting because we can understand that there's been a change, but we may not be able to draw correlations as to why that change has happened or explore that change with a client, because we're not collecting them often enough for them to actually sit and recall and talk through experiences that they have had over the last little while to inform the clinical process and inform clinical discussions. That said, it'd be very difficult to start collecting on a frequent basis in the way we are currently doing things, because it's a bit of a black box for both the clinician and the client, in that they're not presented with insight into the data that they just got. And so they don't see the value in it. And if you don't see the value in it, it's going to be very difficult to convince people en masse, especially people in care, to say, hey, continue to do this on a frequent basis. But when we take away that black box and we open it up and we allow people to see value in the information that they're providing and better understand their health and better engage in care, we create an opportunity where they're more than willing to provide frequent feedback. And as an industry or as a clinician or as a clinical leader, we have much better information to go off of to improve care services for that individual, but then at the clinic level and at the system level across the board. So the model of measurement that the Yale Measurement-Based Care Collaborative uses to describe that is Collect, Share, Act. So I'm going to pass it over to Sandy to give us a bit of an overview of Collect, Share, Act, and then we'll jump into the share side, which is really where we're going to spend most of our time today. So I'll leave it to you, Sandy.
Thanks, Jesse. So we've developed this model called Collect, Share, Act, which we think is a simple way of describing this, this clinical process of measurement-based care. So just to break it down and collect, first, we start by presenting a rationale for what measurement-based care is, and we decide together with the client about what we're going to measure. And then we routinely collect these measures throughout mental health care. So for example, if I'm working with someone who has some anxiety symptoms that's limiting their ability to engage in pleasurable activities, we might together decide both to measure anxiety symptoms, but maybe also a quality of life measure that's going to get at some of the challenges that they're having with their day-to-day activities based on what they say is important. And then depending on the workflows, you might have the client complete the measure right before each session at whatever frequency you've decided upon, or at the very beginning of the session, potentially while they're even sitting in the room with you. Then in Share, we review the measures together, and we're going to spend a lot of time on Share today, so I won't go into too much depth, but it's an opportunity to pause and reflect. And I know we're not supposed to have favorites, but it's always my favorite. I love Share because it's sort of a low pressure opportunity to just explore and talk and be curious together. So for example, the client might reflect on their anxiety symptoms or items on the quality of life scale that might have been particularly relevant for them in the past week or two, or however long since we've seen each other. Share also means sharing the data with the whole treatment team. So if you're an independent practitioner, this might not be as relevant, but if you're working in a larger system where other people might be working with the client, then sharing the data in the medical record or however, whatever system you're using in order to share makes this data available for everybody else, and it helps everyone to be on the same page. Then in ACT, we brainstorm together about next steps to take. We might look at how treatment has been going and look at trajectories over time. Are we on the right path? Should we stay the course, or should we change things up and do something different? And underscoring all of Collect, Share, Act is this transparent and collaborative process that allows clients to be the driver of their care, both through filling out the measures and also through these transparent and collaborative discussions around what the measures mean. So in all, Collect, Share, Act is simple in practice, and it can be quite quick, but it's also easily integrated into your usual work. And we like always to talk about value added. Jesse has already referred to this idea of value and ensuring that the practice has value. And we absolutely believe that this pretty brief intervention adds a lot of value in terms of both enhanced outcomes, enhanced engagement. And we'll talk a lot about all of this over the next few minutes as we go through the rest of the webinar. So thanks, Jesse.
Awesome. Thank you very much. I think sometimes when we refer to measurement-based care, we make it clear that measurement-based care is not a collection exercise. It is a clinical process. And I think the part to me that makes it a process is really the share piece. We can collect information or we can collect feedback from clients. We can act on it, but it's the share piece where, for me, the magic of measurement-based care happens, and the part that makes it a true process. So I'm going to stop there and pass it to Elizabeth to speak to some of the research that is around specifically measurement-based care, but really honed in on the share part of things. So I'll pass it to you to share some of the data and the insights that are already out there for us.
Yeah, absolutely. Thanks, Jesse. And I do want to start by just saying that it's really part of our mission at the Yale Measurement-Based Care Collaborative to be very honest about what we know and what we don't know from the MBC research to date. There is a recent proliferation of published studies on MBC, and we're seeing more and more rigorous designs and comprehensive reviews coming out across various settings, patient populations, and countries really all over the globe in the past decade or so in particular. And overall, what is out there so far is really exciting. The MBC research to date shows that a little measurement routine in psychotherapy can actually have a relatively big impact. So specifically, when you look at usual care mental health services with MBC, we're seeing that they result in faster symptom reduction and an overall improvement in patient outcomes when you compare that to usual care mental health services in the same settings with the same patients that don't have MBC as a component of the practice. And I will say, just for the honest part, the research has been tricky to summarize to date because there's a lot of different terms out there for MBC. To many partners that I'm working with in the practice field, MBC is still a new term. And so sometimes this practice has been referred to as feedback-informed treatment and routine outcomes monitoring and other terms. But MBC in some form really has been around for a long time in mental health services and truly is a solid component of an evidence-based approach to practice. So that's a little bit about just kind of MBC research overall big picture. And when we talk about the research supporting SHARE specifically, remember how Sandy was explaining that the client and clinician are looking at these measures together. They're thinking about and talking about what the scores mean. So in MBC research lingo, the value that comes up in that part of the practice, in the SHARE part of the practice, we really see in studies that focus on feedback. So there are a lot of research studies that focus on feedback. So here's just a few snippets on what we know so far about SHARE from the research. First of all, we know that client outcomes are better when feedback is provided to the clinician and the client, as compared to data just being collected and not viewed or used. Sometimes I refer to that as a data black hole, right? So we want to really get away from that and make sure that clinicians and clients are looking at the data together, and we see that that is associated with better outcomes for clients. We also have seen from the research that when clients are involved in this progress data review and discussion, they report a greater sense of hope and attunement to their own symptoms, as well as insight into, their needs and strengths and difficulties. We've also seen from some of the research that when clients have the opportunity to review their own self-report measures in session, they're more likely to endorse a greater sense of involvement in their care. So they're receiving that information about their own health, as Jessie had said, but there's also something that's happening in the care process where clients are saying it's not just attunement to their own symptoms, but also involvement in care that is being experienced as part of that SHARE process. And then just as a quick wrap up, going back to the honest part about the shortcomings of the research findings, this is another area where we just need a ton more research. So for example, there have been some really excellent qualitative studies that gather client perspectives when they're in different feedback conditions. And that's the kind of research I think we need some more of, is to really understand how is SHARE from the perspective of the client impacting their experience in care and ultimately their outcomes.
Awesome. Thank you so much, Elizabeth. Super helpful. I think on our side, one interesting thing we see, and we can't say that this is the direct cause by any means, but the correlation, a very strong and exciting correlation, is there across millions of assessments that have been completed across thousands of clients from Greenspace, is across the board on average, the more assessments people fill out, the greater symptom improvement we see. Again, can't directly turn and say that is what the cause is, but it's definitely an exciting correlation to see that the more people engage, the better their symptom improvement is. And I think from a common sense perspective, seems like it would make sense. And that if someone is engaging and they understand their health better, they're having better conversations with their therapist, and therapeutic alliance is increasing, that likely they'd see better symptom improvement as well. I think awesome to have the information just around what the research says and what it doesn't. I'm going to pass it to Amber and hope that you can share with us a little bit from your experience around how to actually implement SHARE. So great. We know we want to share. We know we want to have great conversations. From your experience, just some learnings that you have around how to approach sharing with clients.
Yes, absolutely. I'm happy to talk about SHARE. Isn't this so meta? We're sharing about SHARE. It's so exciting. And just to go back to something that Elizabeth said in the research, I really like to think about patient empowerment and shared decision-making. Isn't it so incredible that patients feel or clients feel like they have more empowerment when they're just receiving feedback and information? So we really love to see that. And that's part of why Share is also one of my favorite parts about MBC. And as Sandy was mentioning at the top, it's really the opportunity that we have in working with the client and the clinician to just get curious together. This is that moment where we're just going to say, hang on, let's pause, and then really take a step back and try to reflect on what's happening together in the treatment. So tactically, and I'll talk a little bit about the process as opposed to the implementation of this piece, but tactically, what we would want to do first is we just want to orient the client to the results. So we might show them either in a graph if you're really fancy, or if you're doing it old school, you might whip out that questionnaire, that paper and pencil form, or maybe both, and just tell the person what those scores mean. So you might even do some reminders about how to understand what a score of 60 might mean. So I might say something like, well, I'm noticing that, this score is a 60, and that means that these symptoms are falling in the moderate range, or this score is an 80. And so that lets me know that these symptoms are falling in the severe or in the high range. So really just orienting the person to what they're seeing. And then this next piece is really where the magic of what skilled clinicians already know how to do starts to happen with measurement-based care. So the clinician just gets curious with the person next to them about their experience. And in measurement-based care, we typically would do this with a series of open-ended questions and prompts. And so because I'm a child and adolescent psychologist, I might even say something like, okay, so what's the vibe that you're getting off of these scores right now? You might say something like, I'm wondering what you think about these scores, or what, if anything, about this is making sense to you? What's not sitting quite well for you? And this is also a chance for us not just to see about where there's alignment with the person's experience. We also want to see maybe there's some places that are not quite lining up. So I might pitch a question like, what's not lining up for you? Or is there anything about this that might be surprising for you in any direction? So usually, if I were a teenager now, I might be saying something like the process is, it's giving Goldilocks and the Three Bears, but make it measurement. So that's what's happening. We're really trying to get a sense about what's a good fit and what's not a good fit. And so really there is that chance to see about whether or not there's a not quite right element of the data, and really then again checking back to see if it matches that person's subjective experience. So ultimately the goal is to really just try to understand and come to some sort of understanding for the person about how these data are making sense for them in their understanding of themselves, and also in their understanding of their treatment going forward. Now, one of the things, Jesse, that I have found that can be, and I think that many folks who are doing measurement-based care have found can be a hang up for folks, is that they worry that they need to have this really extensive knowledge of every single measure that exists, right? So they might feel that they need to know like the nitty gritty under the hood psychometrics of a library of different measures to be able to do MBC well. And so while it is important to be familiar with the measures, absolutely, the good news is that you don't have to be a psychometrician or an expert in a library of measures to do MBC well. All you have to do is be willing to get curious with the person and really rest in that curiosity. Ask those open-ended questions. Listen to the person, check for understanding. These are muscles that really skilled clinicians have already built. And so it's okay to flex those muscles, when you're doing measurement-based care. And in the measurement-based care collaborative, we have this really wise psychologist, Dr. Jessica Barber, if you all have ever heard of her. And she has this saying of, it's how you use the measure that matters. And that's what we really like to underscore when we think about Share.
Thank you very much, Amber. One thing that just comes out of what you're sharing is obviously be curious was a theme throughout. Interesting to me in my past life, I guess, prior to being with Greenspace, we launched at a youth mental health charity something called Be There. And it was a resource for anyone to learn how to support people in their life that may be struggling with their mental health. And one of the key pieces in it, there was 5 golden rules. This wasn't one of the golden rules, but it was a piece that we used in like sharing the overall resource a lot, which was be curious. And it's something that I've learned in my personal life when people are struggling, of like the effect and the power of curiosity, both in one, better understanding the person that you're speaking to and building relationship, but also opening the door to them by showing just how much you care and how interested you are in listening, and engaging in whatever support they need. And it's just interesting to me that transcends personal relationships into the professional world of like that same sort of piece around be curious, keep an open mind, and really want to learn from the person that's there to get help from you. So I just love the be curious trend through both. I'm hoping that you might be able to take the examples you just gave us, just of like ways in which to approach share and share a tangible example of it in action from your experience.
Of course. Well, let's go on a journey together. Let's just I want to paint a picture for you of what this looks like in an adolescent intensive outpatient program, for example. So for those of you who might not be familiar with an IOP or an intensive outpatient program, it's a group-based treatment setting or treatment model where there's a use of an interdisciplinary treatment team, as well as then a primary clinician who's working together with a particular youth in that group. And so as Sandy was mentioning at the top, share doesn't stop just with thinking about that patient to client or client to clinician interaction. It really extends then also to the interdisciplinary team. And depending on how you set your model up, it might also extend to other people that are involved in that particular client's treatment. So for teenagers that are enrolled in this IOP, they might administer the measure on a Monday. They might receive the measure on a Monday. They take their scores, and their primary clinician takes a look at those scores, Monday afternoon, Tuesday morning, and starts to digest some of that material. The first group of the day on Tuesday is a goal settings group where teenagers are getting together to think about what their map for the day might be. And that's the opportunity that they then review their MBC scores with the primary clinician. And they also have the benefit of hearing feedback from other teenagers about what's happening or what might not be fitting quite right, or other elements that the teenager might want to think about. But we're not stingy with the share. It doesn't stop there, because then on Wednesday, we go into the interdisciplinary team meeting. That primary clinician goes into that meeting, and then the MBC data really serve as an anchor for the discussion of each of those youth in regards to how they're doing in the program and what are the tweaks that we want to be making related to the data that we're getting from MBC and also other sources of information. And then because our teenagers, when they come into the program, we're very transparent with teenagers and families about the information that's going to be shared back and forth. We have a mid-treatment family meeting where we get together with the families and we review 3 weeks worth of MBC data and say, look at where we started. Here's where we are now. And then again, we use those MBC data to start to sketch out the roadmap that's going to be ahead for those remaining weeks of treatment. So that's a little bit of a picture of how we might do share throughout a couple different dimensions in that kind of setting.
Awesome. Thank you, Amber. So this is the part where we'll get into a bit of an activity, which I think is good timing, as Holly saw your note in the chat about visuals being helpful, which is exactly what we're about to lean into. I think one of the things that has come out of measurement-based care and Yale measurement-based care collaborative's process is the idea that it's a simple activity to look at data and start to think about or create some hypotheses around what that may mean. And that said, a little practice can probably go a long way to just helping people feel comfortable with it and seeing how others would respond as well. And the idea that it doesn't have to be a concrete, absolute answer, and that the exploration is a big part of the overall process and activity. So I'm going to pass it to Jessica to take us through an activity that will take a chunk of time, but really looking for the people in the audience to participate. Throw your insights and your thoughts into the chat. The chat is now open. It was disabled for a bit, but it's open now. So please jump in. But Jessica, take it away and walk us through.
Hopefully everybody will be very excited and jazzed to give responses in the chat. And I'm going to click here just to make sure I can see the chat. So this exercise is one that we love to use, and we call it PHQ-9 3 ways. You're seeing a PHQ-9 right now. So I did see in the chat that somebody asked the question of, are we using the same questions for every client? And typically, although there are some circumstances where there might be tailored or personalized measurement-based care, for the most part, when we're talking about MBC, we are talking about using a standardized measure. And this is an example of one we use a lot. And so we know that there are a lot of clinicians who, number one, perhaps don't use measures like this at all. This might be something that's very new for folks, or there might be some who use these measures, but they're used to doing this sort of as part of assessment where they look at their measures outside of the session. They really have the opportunity to examine all of their data and think about conceptualization. And this is a very different way of thinking about using the data where we're doing it in a collaborative process. It's really collaborative from the beginning to the end. And so we like this exercise because for folks who aren't used to doing this, what we're essentially saying is we're going to kind of take stock of these measures really quickly with the client often in the room with us so that we can get a feel for what they're telling us. And that's really the first step of share. It's sort of looking at the measure, ideally looking at it together with the client and saying, what is this telling me? So what we have in front of us is a PHQ-9, and this is inspired by a fictional client. Actually, this one's inspired by a real client. And I'll ask you all to just take a peek, just stay here for a moment and just look at this. Some of you maybe are familiar with PHQ-9s. This is old news for you, but for those who are new, just take a moment and sort of see what you're noticing on this measure. We put a few notes in the margin there for you also, since reading these kinds of things on a screen can sometimes be a little bit challenging. So I'm sure that I'm guessing that most folks here are clinicians, and as good clinicians will, I'm sure you're having some thoughts. I'm sure you're having some ideas. Dan Warner is ahead of the curve, jumping in already. I love it. I would love to see your thoughts. So as we're looking at these, I'll give you a little sneak peek. We're going to see all of these PHQ-9s have moderate depression, but the patterns are going to be where it's at. So we're seeing some comments already. I'd love to hear, what are some hypotheses you're formulating? What are some ideas you have about what might be happening for this client? What are some things you're wondering about? I'm going to give you all a minute to throw a few more answers in before I start commenting on what I'm seeing already in the chat. I'm seeing a few more. This is awesome. All right. So I'm seeing from Dan, this person feels acute impact on their life from their symptoms. So you're really homing in on item 10. And I think that's fantastic because there are patterns of symptoms, and this measure, which is kind of unique to this measure, asks about how distressed people are. And that's actually really important data to understand how much they're troubled, how much their functioning is impacted, as well as the distress. Jennifer thinks this is excellent for goal focus. Jennifer, I think you might already be a little bit ahead of the curve thinking about ACT. Absolutely. Part of why we like the individual items is because it does help us pinpoint a little bit what might be some topics to explore more when we're going into the ACT part. So we're focusing on share more today, but we're obviously doing something with this information. It doesn't stop at share. And so absolutely, these individual items really help us with that. We're seeing somebody who wants to do some assessments. So yes, we're seeing the curiosity. I'd want to assess for environmental or primary causes of the symptoms. So let's get some context. Absolutely. So we understand that we're seeing some patterns of symptoms, but that's just part of the picture. We want to go deeper as Dr. Childs talked to us about that. Get curious. Maybe further discussion. Joshua is suggesting we want to spend a little more time maybe drawing out more information on these symptoms. Absolutely. Let's learn more about what is happening with each of these. And we also see someone who's probably, I don't know if Milena, if you are a health psychologist, but you're speaking to my health psychologist heart because you're asking the question of, could there be some insomnia going on here? And Fairly Barnes, yes, what kinds of physical or medical things might be happening? So we're seeing a lot of different things here. Wow, the chat is happening so quickly. And look at Jesse, I love your comment. what kinds of impacts might the impact of poor sleep be having in other areas? Yeah. Yeah, so Joshua, I'm just scrolling down and I'm noticing, and others maybe have pointed this out, but you're acknowledging that there are a lot of symptoms here, but items 1 and 2, which are, for those of us that work with a lot of depression, we know this is where it's at with depression. These are the 2 primary symptoms, and that's definitely a discrepancy. So Amber talked about that. When we see those, it's definitely something to get curious on. And some strength-based discussion, because some of these things aren't as much of a challenge. Yeah. So there are a lot of great things here. I'm seeing people are asking questions. I'm seeing people are pointing out some things. So this is really fantastic. So this is one pattern. And what I love is that, you know, we're not going to just use this measure in front of us and say, okay, we know exactly what's going on. Let's move on to treatment planning, or let's move on to ACT. We're going to pause here. And I know that Sandy talks a lot about this so beautifully, of using share as an opportunity just to sit and to pause. So I think we've heard great ideas about this one. Shall we move on and look at the second example? Would that work? I know I didn't get to everybody's answers, but definitely please keep them coming. So it might not look like this screen changed much, because this PHQ-9, I'm kind of giving away a little bit here, is almost identical to the last, but there is one big change in particular. So what are you noticing about this one? Are you having any different ideas or hypotheses? Andriana says, number 9. Absolutely, that's the big difference. Yes, thank you, Sandy, for pointing that out. I missed that. Tony's thought about open-ended questions about what the person wants to work on. And I'm seeing a lot of people jumping on item 9. Yes, absolutely. So this is the big difference here. And we notice we still have these zeros on items 1 or 2. So once again, yes, Jay, you're literally reading my mind as I'm speaking out loud. That big discrepancy once again. So that's something to explore. And yes, item 10 is also elevated from the last one. So we have, once again, this is moderate depression. So these scores are both reflective of the same level of depression, but once we look at the items, we get more insight. We have a lot of fruitful ideas for things to explore. And the measure, and as you can see, like I mock these things up as forms, because I'm used to old school, where I'm literally like sitting in the room and we put the PHQ-9 on the table and we come along and we're looking at it together. So there is definitely nice, fancy new software and tools that allow us to do this in a far more technologically advanced way. But so we're looking at these together, and we're having this opportunity to use these individual items to really gain greater insight together and to explore that. So there's so many comments here. I'd like to see 1 or 2 more before we move on. So Tony wants to know what's changed that might not be asked in the tool. Absolutely. The tool isn't going to give us everything. So we want to explore what else might have changed, what might be contributing. So let's assume maybe this is the same client, and maybe this is the next administration, and now all of a sudden something has changed. We might want to understand that, you know, what might be going on that might contribute to what we're seeing. So a lot of people really, really giving excellent responses related to safety planning, exploring risk, and so on.
One of the things, if it's okay, Jessica, one of the things I just noticed from Erica's remarks here about, you know, the ways in which people are looking at the language and understanding it, that gives us some additional insights as to their experience. I remember talking with a teenager who was experiencing significant amounts of depression, as we all would think about it clinically. But then when the person was filling out the form and it was asking them if they felt depressed, or sad, they were like not marking those items. And so we're surprised that their scores were so low. And so we started to get curious about that together. And the person said, I didn't say I was feeling depressed. I told you I was feeling a type of way. And so then we started to try to get some language, right, around what does this mean to you and how might that help other people understand what you're talking about when you're describing your experience. So some psychoeducation was definitely able to happen there. So thank you, Erica, for that remark.
Yes. And to kind of piggyback off that, sometimes we're using the measures to develop that shared language, which is one of the strengths of measurement-based care, that it allows us to do that it gives clients other ways to help us understand what their experiences are, and to communicate with us in a different way, and for us to generate that shared language around what these terms mean. But I think this example also gets at, with the language of like bothered, for example, that we're also developing a shared understanding and language around how we're even using the tool together, because we have to make sure we're all utilizing the tool together and thinking about the instructions in the same way, which could also be part of the education that happens. We're beginning our collaboration, and that's collaborating on all of the elements, including the way we're talking about symptoms or the clinical presentation, but also in utilizing whatever tools we're utilizing, and the measures are one of those tools. And we're seeing that people are having other hypotheses about diagnoses. So this is really fantastic.
One thing that stands out to me, I just saw Jay's comment, which I think is interesting, of like, as the person has moved on, they're describing things that would likely be linked to anxiety or depression, but are answering no to the questions above. And could there be a lack of understanding around the definition of it? And I think that's just another great example of the way the discussion with a client would, like, how this can help inform the discussion with the client and create a better alliance and understanding of what you're accomplishing in care.
Yes, and Joshua is pointing out that some folks might be reluctant to talk about certain things at first because of stigma, and that ends up creating another really fantastic opportunity when we're hearing one thing from the client when they're talking to us, and the measure is showing us something else, because sometimes we're actually seeing discrepancy in what we're observing and what the client's telling us with what we're seeing on the form too. So that's another place where things sometimes don't line up, and that creates another opportunity for that exploration, which could be related to stigma, or again, we need to develop a shared language. There are a lot of reasons. There's never just one reason, and I think that's the key point. And that's why we want to take time for that collaboration and that curiosity. Should we move on to the last one in our last couple of minutes for this exercise? All right, so now we have just another small difference. So again, we are seeing moderate depression, and now we are seeing items 1 and 2 having some symptoms being endorsed. And I'm seeing that Jennifer is asking about the frequency. That really can vary. I know I like to give them at every visit. It kind of depends on the treatment you're using, the measures you're using, and so on, and also a collaborative decision with the client. But typically, I'm utilizing them at every visit, and perhaps others can share if they have different ways of doing it. So in this one, we're actually seeing something that sounds a lot more like depression, what we would be expecting to see. But one of the things that I do want to highlight is that, let's say this person's referred for depression, and we look at the PHQ-9 and it looks like depression. Just like when we saw discrepancies, this person's referred for depression, and we look at the PHQ-9 and it looks like, I'm not sure. We want to also make sure we're still pausing and doing the same process, even when the measure kind of maps onto what we would expect to see, because there could still be things that we're missing. There could still be places for education that we might want to make sure that we are pausing for. And so we still make sure that we don't make assumptions. And that's really the key. There are excellent clinicians on this webinar, obviously, who have a lot of ideas about what this might mean, a lot of hypotheses about the clinical picture. So you've got excellent training. And now it's about utilizing what we're seeing in front of us for that collaborative conversation with the client, so that we have a shared understanding together, so that we can make sure we're really aligned on what it is we are working on, how are we conceptualizing this? To get back to that question that someone had posed in the chat, we should talk about what we should work on. This is the place where we can make sure we're really aligned on our clinical understanding, so that we're in the best position possible. And certainly excellent clinicians, as we've heard others share today, we get good at doing this. The measures to me are just one of the best ways of anchoring this kind of conversation. We might be successful at aligning in this way, even without the measures. But I personally find it's so much easier to align and to stay aligned when we have a tool like this in front of us to draw from. I'm going to pause and I'm going to turn it over to my fellow panelists to see if anybody has any other thoughts about what they're seeing in the chat. It's going by so fast, or other points you'd like to make.
I'm just really impressed with all of the feedback that everyone's giving. And I think it really demonstrates the kinds of the spirit of curiosity that we've been talking about, and the fact that we can all come at the same pieces of data from different perspectives and have different thoughts. And that ultimately, as so many of the comments have made, it's about what the client or the person that we're doing this with and the feedback we get, which is at the core of SHARE. And these are questions we have, but they're not the answers, and that it's the truth that the person brings into the room and the shared language that we develop together as part of this process that makes it so meaningful. So it's delightful to see all of these comments. It's just been really fun to watch.
Thank you all for your fantastic participation.
Awesome. Thank you so much to all of you, to the attendees, but Jessica specifically for taking us through that. I think super helpful exercise, and I think very much displays the point that we're making. One, that like practice helps, and going through it with others and peers and seeing what their thoughts are, in that they're not concrete answers. It is very much a thing that you need to look at and need to try to understand. And then there are pieces that will stand out that allow you to be curious in session and have a discussion with clients and build therapeutic alliance and build understanding around what you're trying to accomplish in care. There are a lot of questions that the panelists have been answering throughout, but I also think there's probably ones that are really great and are probably being missed by some of the attendees that aren't reading them. So I wanted to go through a few of them and make sure we capture just some that may be applicable on a wide level. One that's come up a couple times that's interesting is, and I forget, I can't find the exact name, but someone brought up the ORS-SRS and asked about the difference between measurement-based care and the ORS-SRS. So I would love for someone to take that on, because I think that's a relatively easy answer, just around like the fact around measurement-based care being agnostic to the type of assessment, and that it's the process that you go through with that assessment. So I don't know who would like to take it, but one of our panelists.
Jesse, I think you actually just answered the question that measurement-based care is the clinical process. It's the umbrella, and it is in fact agnostic to the measurement tool that's used. And that one of the challenges that we have when we're looking at the research and trying to figure out the signal from the noise is all of those different terms that are used. And sometimes the same term is used, or different terms are used to mean the same thing. Sometimes they're used to mean different things, and they're the same two terms. And so it does get challenging out there. So if you're confused about the difference between feedback informed care and measurement based care, don't worry, so are we. And part of what our mission is, I think in some ways, is just those basics of trying to develop not just a shared language when we talk to our clients, but a shared language with the field about what we mean when we mean measurement based care. So that's a great question. So glad to have the opportunity to answer it.
Awesome. Thank you, Sandy. And I think to that point, measurement-based care is really agnostic to the assessment that you want to use. And I think in the past, the way it has worked is at ORS-SRS as an example, is someone may be using a system that is specifically built for that assessment. And one of the gaps when that happens is a key part of measurement-based care is customization. And what that means is if you or I or whomever is working with a client that is in an eating disorder program, and they also happen to have addiction issues, the eating disorder program may have a set of assessments that they want applied across every client. but the ability for a clinician to then say, hey, this client is dealing with something very specific that is different. Let's add an assessment in. And so that's where, when I use the word agnostic, is the system that you're using should be able to apply any evidence-based assessment to it, so that it's the ORS, SRS, great. And now let's add on a functioning measure or whatever else, and give us the flexibility to find out and dig deeper into the areas that we or our client want to dig deeper into. With that, there's a great question from Joshua Miller, that Elizabeth answered. So maybe I'll throw this one to you. Can this be applied to short-term modalities like brief solution-focused therapy or other forms of single-session counseling, or does measurement-based care work best in long-term form?
Yeah, I think it's a great question. And I had said to Josh, although I'm interested what others think, I think this is an area where the MBC practice is really surpassing the research right now. We don't see this showing up in the research literature, but we're seeing it happen in a variety of treatment modalities. I had mentioned that there is a group in Wisconsin that does school-based SBIRT, which is typically about 4 sessions, and it's with young people who are at risk of substance use, and it's motivational interviewing oriented. And they use the Gain Short screener. They do it every session. They're using that to guide their conversations with young people. So we're seeing it happening in different areas of practice, but there's not much research, at least that I've seen, on those modalities yet.
Awesome. Thank you, Elizabeth. Another good question. We'll probably get one, maybe 2 more in, from Morgan Priest. And I'll throw it to Amber because of some of the conversations we've had in the past on the panel, and just generally where you comment, and Elizabeth called this out as well, about putting the young person, in your case, in the driver's seat. So the question from Morgan is, how could you adapt measurement-based care to working with clients who do not see the value in measurement-based care or any type of measurement feedback tool? Working with the youth mental health sector, this is sometimes a challenge, or this is often a presenting challenge.
Y'all, teenagers are usually, I've said this before, they're usually not doing cartwheels to come into treatment as it stands, and most often feel that they are in treatment at the behest or probably at the requirement or expectation of an adult figure or someone else, or a system level kind of intervention might be happening, like a justice system intervention. Or a social services intervention. So we work really hard with teenagers to really support their buy-in by thinking about the rationale. And so I'm thinking actually about some of Dr. Barber's work and really helping to provide the rationale for folks that, hey, this is an opportunity for me to really hear you first. And most of the times when we're working with youth, they might have this experience of sort of not being listened to, or really feeling like their experience or their desires or their wishes are not prioritized. And so I always say, look, this is going to be the call out tool for me to really make sure that you are being heard and that we take every opportunity that we can to hear your voice. And this is going to hold me accountable to that. And I actually get a lot of mileage out of this with youth to really help them see that. I also noticed that in working with group-based settings, and I've seen some threads coming through thinking about group applications for this, there is also a really powerful impact of other teenagers. If you see somebody who's also benefiting from that particular intervention, especially if they were maybe a hard sell in the beginning, that can also be really effective. So seeing how it might help somebody identify a different goal or get validation or support, which is frequently, I think, a really big bolster for teenagers or for all of us, actually, we've gotten some good mileage out of that as well. So that's what I would say in a nutshell.
Awesome. Thank you, Amber. Before we close, I wanted to take a second to lean into the momentum side of things and back to the conversation or the discussion at the beginning, just around the increasing momentum of measurement-based care. And obviously, all of you are extremely involved and committed to the implementation of measurement-based care across the industry. So I'm curious, if you saw the industry swiftly move to measurement-based care, tomorrow every clinic across North America was using measurement-based care, what would excite you in 30 seconds or less? What would excite you the most? I say 30 seconds or less based on the timing. What would excite you the most about that movement?
For me, I think it would just be about transparency. I think mental health services, especially for those who aren't engaged yet, but also for people who are already engaged, it can just feel really mysterious. Like, people don't really know exactly what they're going to be getting. I love the way measurement-based care really operationalizes therapeutic alliance and makes everything clear. We all know what we're doing, we all know what we're working on, and we all know why. And we're constantly keeping an eye on how it's going.
I actually just love this question so much because I love dreaming about what mental health care could and should be for anyone who's receiving it. I think if the industry moves swiftly toward MBC, and not just swiftly, but also did it well, I would worry a lot less about what quality of care people receive in everyday mental health services. I think if we're, scaling up high quality MBC and usual care mental health services, that means regardless of geography, income, education level, insurance status, individual strengths and needs, everyone would start their session with a little personalized, data-driven conversation starter. And I think that would just really advance the equity and quality of care. So I love MBC as just a really simple and powerful practice to kind of level the playing field for what everyone's receiving when they go to see a provider for mental health services.
So if you ask me this question every day, I would have a different answer because there are so many amazing things that I love about measurement-based care. But what's really, I've been thinking so much about provider burnout lately and the stress on the system from all the things. And it makes me remember in some early implementation work when providers would tell us how excited they got to see in writing, on graphs, in paper, how their clients improved and how exhilarating it was for them for the first time to have, in some ways, this concrete evidence of the impact of their work. And so to me, that's what I'm thinking about now is helping providers who are working so hard and giving so much of themselves to have a way to really demonstrate how amazing they all are.
Amazing. I love that. And I think that's our experience as well. Often when a clinic implements is the providers being able to actually see the difference they're making in quantitative terms for the people that they're serving.
I think, for me, what's exciting is dreaming about or thinking about, what would it be like if we really trusted the wisdom that was inside of people about their own experiences? What would it be like if we really gave people the tools to take the lead in their own wellness? That is at the core of patient-centered practice and empowerment. And so I'm all the way here for that. And I'm all the way here for the future of MBC. So I would love to see that, that really come to fruition if the field and the industry really takes this up.
Well, we got lots of people working to try to make that change and try to help increase education and the ease of measurement-based care. So hopefully we'll get there at some point. We're at the top of the hour. A couple of things. One, when you're logging out, please take a second to fill out the survey if you can. The next session will be responsive both to the questions that we got that we weren't able to get to. So thank you for those that submitted them, despite us not verbally going over them. And the next session will be on November 3rd from 1 to 2 p.m. We're very excited about it. It will try to cover the most frequently asked questions around measurement-based care and then specifically focus on implementation at a leadership level. So how do you think about bringing measurement-based care into a clinic and the approach that you should take when doing so? Thank you for attending. Very much appreciate it. And thank you to each of our panelists for your participation. And on behalf of both the Yale Measurement-Based Care Collaborative and Greenspace Health, very much thank you for taking the time, for making the time, and for your interest in learning about measurement-based care. Have a great week, and we'll hope to see you on our next panel. Thank you.